Hey, thank you so much for a wonderful introduction. I really appreciate it. I'm very excited to be speaking to you all, and I'm very honored to be here. Thank you for the opportunity. Um, I'll be talking about the focused ultrasound treatments within pediatric patients with brain tumors, but I really want to, these are my disclosures. Really, there's nothing other than the fact that it requires a really great team to build a successful program. And, it's lovely to see in Pakistan, the collaboration that exists between surgeons, neuro-oncologists, I'm sure anesthesiology, radiology, critical care. But it's so great to see that here at Children's National, where I am, in order for us to build programs like this. And so I want to dissect this topic into three objectives. One is to review the neurosurgical applications of focused ultrasound and the history behind it. Two, to examine the current and potentially future brain tumor clinical trials related to focused ultrasound for pediatric patients in particular. And I want to break that down into defining what high-intensity focused ultrasound is versus what low-intensity focused ultrasound is, and then illustrate some patient cases as well. So moving forward, what is focused ultrasound? As you all know, ultrasound is ubiquitous within the medical community. It's used from all different services, but it also has some therapeutic implications as well. And we all know that focused ultrasound essentially is a non-invasive ultrasonic waves used to either heat or ablate tissue or mechanically disrupt tissue or potentially activate medications. And it's used potentially because of a curved transducer or a phased array or lens that can target specific areas within the brain itself when we think about brain applications. And there are many companies that exist that manufacture their systems. Here at our hospital, we have the Exablate Insight system that is MRI based, but there's certainly other focused ultrasound devices that are, for example, implantable, and others that are navigation-based as well. But essentially, this technology involves a non-invasive process, something that's so-called incisionless, and it really marries two different technologies, including the MRI and the actual focused ultrasound itself. And so this diagram really illustrates the biological effects of focused ultrasound on tissue, which really can be categorized as predominantly thermal or mechanical. So the top panel illustrates the effects that have been demonstrated so far in humans. In the top left, you see thermal ablation. And so this is essentially when high-intensity focused ultrasound is delivered through the intact skull, and this results in a coagulative necrosis lesion that's millimeter in precision and used, for example, for movement disorders like essential tremor or tremor-dependent Parkinson's disease. In the center, you see blood-brain barrier disruption for opening for drug delivery, and that's utilizes low-intensity focused ultrasound and microbubbles that essentially cavitate or excite, and because of the excitation leads to contraction and expansion, and that disrupts the tight junctions of the endothelial cells, which allows for the delivery of a therapeutic agent. And certainly we see neuromodulation effects as well with low-intensity focused ultrasound. The bottom row sort of illustrates what is currently being researched. Hypothermia, for example, to increase potentially radiosensitivity and immunogenicity of tumor cells, and other methods like histotripsy that mechanically disrupts tissue as opposed to heating it and ablating it and resulting in a lesion. When we look at the number of publications within focused ultrasound from the early 90s to currently, you see that there's been a very large increase. But when you think about the research of focused ultrasound, you can take it back to the early 40s or 50s, where various scientists reported animal and human studies of focused ultrasound being delivered through a cranial window. But it wasn't really until the early 2000s and the mid 2000s that we saw animal studies that translated into clinical trials. one of the pivotal trials in 2013 looked at focused ultrasound for thalatomy for essential tremor, which is now progressing increasingly at various institutions in the US. But certainly there are other experimental techniques and trials with OCD, depression, blood-brain barrier disruption for Alzheimer's disease and ALS, and certainly there have been publications more recently within this year to suggest some benefit with these types of therapeutic interventions. So it's a very exciting field, and I think that it's very innovative, and we're really at its infancy, particularly for pediatric potentially pediatric indications. It's sort of lagging the adult side by 5 to 10 years. So moving on, as I mentioned, there's a difference between high intensity focused ultrasound and low intensity focused ultrasound. I really want to drive this point. With the Insight Tech system that we have, the high intensity focused ultrasound is a 650 kilohertz transducer, and this essentially results in a high temperature ablation. And I'll provide a case example of this. But it essentially heats the tissue that results in a coagulative necrosis. And so this is permanent sonication that's classified as ablative. Contrast that to low intensity focused ultrasound that is a lower kilohertz for mechanical tissue disruption, for activation of medications like sonodynamic therapy, and those indications that are reversible, like blood-brain barrier disruption and potentially drug activation and neuromodulation. So what are the clinical applications thus far within neurosurgery? As I mentioned, we know that, that this has been used, and we are using this for movement disorders, FDA approval for essential tremor, targeting the ventral intermediate nucleus of the thalamus, tremor-dependent Parkinson's disease, but certainly trials and studies targeting psychiatric applications like OCD and major depressive disorder. Chronic pain has also been studied, and brain tumors as well. What put this study that was published in the New England Journal of Medicine in 2016 really put focused ultrasound on the map. And as I was mentioning, this was a randomized trial of 76 patients who had moderate to severe essential tremor and who didn't respond to medical therapy. And so there were two groups, those that were treated with focused ultrasound thalatomy and those who had a sham procedure. And then the hand tremor scores were graded for both these groups. And it was found that the scores improved significantly in the focused ultrasound group compared to the sham group. And this improvement maintained at 12 months. And then more recently, a 5-year review of was also published that demonstrated very good outcomes. So this is a picture of the focused ultrasound machine within the MRI room, essentially. And you can see that the transducer head frame there has essentially 1,024 elements of ultrasound rays that can converge to a point that needs to be treated. This is looking at the actual stereotactic mechanism, and there's an XYZ coordinates that can be adjusted in order to target precisely with millimeter accuracy where you need to target for your treatment, whether that's with high intensity focused ultrasound or low intensity focused ultrasound. This is another picture demonstrating the patient who's affixed to the MRI transducer. You can see sort of this membrane that is overlying the eyes of this patient, and that's filled with deionized water as the acoustic window to allow the ultrasound rays to take effect, essentially. This is a picture of the software system for a high-intensity focused ultrasound treatment for a thalatomy. So we're able to track the different transducer rays that make the sonication, and then obviously adjust the energy dosing or the acoustic energy dosing that's necessary that equates to whether you're trying to permanently ablate or create a lesion, or use something that's less in energy for low intensity treatments. When we're doing the treatments for essential tremor, they can be patients or adults can be monitored awake, and you see a considerable benefit in terms of their tremor itself. These are images demonstrating the radiographic and clinical results, for example, of the VIM thyrotomy for tremor. Again, patients are able to go through this procedure without an incision, and it's an outpatient procedure itself. So something that really is of interest for patients, and has very good outcomes thus far. So moving on towards the clinical trials for pediatric patients, and this is sort of what I want to talk about for the remainder of this talk. But we have high intensity focused ultrasound, and we have a trial that's looking specifically at benign centrally located intracranial tumors. We've also written up a trial for dystonia that hopefully will begin in the coming year. And then we have trials for low intensity focused ultrasound, specifically for brain tumors. And I want to talk more about this in detail. One is for sonodynamic therapy, which utilizes the compound ALA, which we know about within surgery as well, and activating ALA with low intensity focused ultrasound, and then a separate trial with blood-brain barrier disruption and the use of doxorubicin for DIPG. So we'll talk about these trials in more detail next. So looking at high intensity focused ultrasound, this trial, the eligibility or inclusion criteria are patients ranging from 8 to 22 years with essentially benign centrally located intracranial tumors with minimal hemorrhage risk. So these tumors can include SAGAs, tumors, pilocytic astrocytomas, DNETs, hemartomas, and so on. So we enrolled our first patient in this trial in January 2022, a 12-year-old child who had an asymptomatic benign tumor, a low-grade astrocytoma. And so for this particular patient where the tumor was located in the occipital lobe, the options were discussed with a surgery. Certainly there's could be morbidity related to surgery given the location of this tumor and its effect on the visual pathways. But the parents were very hesitant towards surgery, and so we felt that this could be a case that could be treated with a high intensity focused ultrasound to see if the tumor could be ablated itself. And so that's what essentially was done. This procedure again was performed in the MRI scanner with sonication times roughly about 3 hours in terms of the treatment duration. In terms of pre-planning, you can see the T2 axial imaging as well as the post-contrast imaging that demonstrates this enhancing lesion. The tumor volume was roughly only about 2 cc's, and you can see our treatment planning and strategy. Again, the goal would be to ablate the tumor so it doesn't grow and to avoid the optic tract because it's an asymptomatic tumor in the ventricle itself. So we performed this procedure successfully, and again, you can see the different energy dosages that are used in more detail. So this required 5 sonications over the treatment period with a power delivery of anywhere from 440 watts to up to close to 900 watts in order to achieve it. And certainly that equated to a higher temperature, again, to heat the tumor and ablate it. And so these are just some post-procedure scans, pre-op to the left and then 1 year post-op to the right. You can certainly see that tumor is remaining, but the central core of it became necrotic, and that's something that we'll continue to monitor over time. These are treatments that can be repeated potentially as well, almost sort of a chronic treatment per se. But again, this is just one patient in the trial as we gain more experience with this to see what types of effects can happen. This trial is done in conjunction with our colleagues at Children's Miami who published their series of patients as well. They have treated mostly hypothalamic hamartomas associated with either gelastic seizures or some type of neurological concern. And in general, their results have been very good. They've also treated one SEGA that grew despite mTOR inhibitors because the family was not interested in surgery. And so these are just some imaging studies that demonstrate their results as well. So we'll see how this pans out. But again, this is one avenue of high intensity focused ultrasound for brain tumors in the pediatric population. So moving on more towards low intensity focused ultrasound, which is really my interest, looking at the different trials that can be formed based on this technology. I want to first talk about sonodynamic therapy. So as I mentioned before, sonodynamic therapy essentially uses the compound 5-ALA and low intensity focused ultrasound. So the therapeutic effects of ALA sonodynamic therapy are accomplished by inducing essentially necrosis and apoptosis directly in the brain tumor tissue via activation of protoporphyrin IX. So ALA, as we know, is a natural metabolite in heme synthesis. Eventually, it's taken up by the mitochondria and it converted to protoporphyrin IX. And so protoporphyrin IX is a compound that's a fluorophore. In other words, it can be visualized under blue light. And this is something that we see as a surgeon, with ALA-guided surgery for gliomas, which I'll talk about shortly as well. But this concept, this compound, protoporphyrin IX, can be excited by higher wavelengths, and that essentially results in downstream effects, creation of reactive oxygen species, lipid peroxidation, essentially leading to apoptosis. And protoporphyrin IX is typically metabolized by ferrochelatase to produce heme. But this enzyme has been shown to be reduced in cancer cells as well. We see this in gliomas and in DIPG cells. And so the thought is if this protoporphyrin IX can be activated either by light or by sound, and this happens through the creation of photons, then perhaps the tumor cell death can occur and have some positive treatment effect for various types of tumors. So as I mentioned, ALA fluorescence-guided surgery is something that is used within neurosurgery, and we know from several studies that this leads to more complete resection or gross total resection and better progression-free survival for high-grade gliomas. And so you can see a picture of the ALA during surgery. The top right shows the brain following tumor resection in white light illumination, and the bottom structure shows blue light illumination where there could be some remnant tumor cells. And so this helps guide further surgery and potentially safer surgery to allow for even a super maximal resection. So how does ALA work? I've sort of described it already, but the working hypothesis is that photodynamic therapy with sonoluminescence being the source of photons essentially generates the reactive oxygen species, and that leads to cell apoptosis. There's probably certain other mechanisms that are in play as well, but this is something that we're continuing to find information as preclinical studies are being conducted. The first in-human clinical trial for high-grade glioma was conducted at Barrow in Phoenix, Arizona. And this sort of helped us start our trial with DIPG tumors. But essentially, at Barrow, patients with recurrent high-grade gliomas were treated with sonodynamic therapy. And the trial design included intratumoral control with 50% of tumor treated with the focused ultrasound. So 4 days after treatment, tumors were resected, and then the parts of the tumor that were treated with focused ultrasound and ALA underwent biomarker testing and compared it with the parts of the tumor that were not treated. And what the group found was that oxidative stress and apoptosis biomarkers were increased in the treated tumor versus the control, kind of again suggesting that this reactive oxygen species caused cell death and triggered apoptosis. So that was something exciting that was found, again, can be translated to other types of tumors, both in adults and in pediatric patients. So with that, preamble, essentially, we felt like patients with DIPGs would be a good population to have a trial with. And why is that? As we all know, DIPGs are very aggressive tumors that are found in the pons. At least in the US, there are about 300 children that are diagnosed per year, roughly between 5 to 9 years of age. But essentially, there's no current effective treatment, despite the standard radiotherapy. Median survival still is 7 to 11 months after diagnosis. And we know that these tumors are not surgically resectable. And so there have been many clinical trials with chemotherapy and radiation over the past few decades, but that really hasn't affected the overall survival. And so looking at the studies that pushed us towards this as a human clinical trial, sonodynamic therapy has been studied in preclinical trials and investigated in malignant gliomas in vitro and in vivo models of animals. And so this is a study that was published in 2019, looking at protoporphyrin IX accumulation that was clearly detected in tumor cells, and you can see that in the picture with the red color. And then to the right, you see, again, animal models demonstrating a reduction or apoptosis of tumor cells, suppressing tumor proliferation between control versus those with sonodynamic therapy, combining the ALA and focus ultrasound, whereas normal brain tissue was unaffected. And even within our basic science group here and with collaborators in Zurich, we found that DIPG cells take up ALA, and again, sonodynamic therapy reduced the DIPG viability, again, demonstrating that this could potentially have a translation into a clinical trial. So with that, the clinical trial was designed, and again, it looked at the safety and efficacy of sonodynamic therapy primarily as the primary outcome measures, secondarily, whether there's any radiographic or clinical changes as well. So essentially, this looks at 18 patients with DIPG in dose-escalating cohorts. Those dose-escalating cohorts include the ALA and increasing the dosage of that medication, as well as the focus ultrasound acoustic energy, and seeing what the best combination of dosage would be safe and tolerable, and then potentially have some type of treatment effect itself. So our sonodynamic therapy procedure timeline, logistically involves all the different teams that I talked about in the beginning. Roughly at 8 in the morning, the patient comes in for an ALA infusion. The focus ultrasound is started 6 hours after the ALA infusion. So around roughly 1 o'clock, the anesthesia team intubates the child. We place the head frame. The child is then placed on the MRI scanner, and the focus ultrasound transducers are placed and positioned. And then the treatment is performed, which can roughly take anywhere from 2 to 3 hours. Subsequently, there's an intra-procedural scan and then a post-procedural scan as well, and the child is usually discharged the next day. So this is a picture I'm sure you all have seen of a stereotactic head frame specifically for the exoblade system. What we found was, particularly for pediatric patients, this anterior crossbar is critical because their head circumferences are smaller compared to adults. This is the same frame that's used for adults, but we use this anterior crossbar. And that also helps with minimizing potential fractures temporally or affecting the temporalis muscle itself too. Just some more pictures of the head frame itself. Again, this is, I mentioned the 1024 elements for the transducer head frame. This is the inside of what it looks like. Again, the patient is positioned into this the the head frame itself with a posterior shift because the tumor is more posterior and deeper, and the head frame itself can be adjusted in the XYZ coordinates. So this is a patient example, a patient who's placed, you can see the membrane that's placed over the child's head. And our initial patients were shaven. Subsequent patients don't require a shave, as opposed to high intensity focused ultrasound treatments, which do require a head shave given the energy dosage that's delivered. At the current time, the treatments are done in the radiology suite, and this is our computer workstation where we're able to design the treatment plan and keep track of the patient and vital signs as well. So this is an example of the first patient that was treated. You can see we're targeting half the PONS in the first patient of every cohort, and they subsequently get their full PONS treated as well. But again, just to be safe, we're doing this in a staged manner. So patient selection from September 2022 to present, we've completed our first cohort and moved towards our second cohort. There are 6 patients that were assessed for eligibility. 3 ended up receiving the ALA STT. Some were excluded because of tumor extension or because the parents declined to participate. These are very preliminary results, and we can't really come up with any conclusions, but there have been some tumors that we've looked at volumetric analysis pre-treatment versus post-treatment with some reduction or at least stabilization of the tumor itself. But that's something that we'll continue to look at in subsequent dose cohorts as well. So as an example, this was a 6-year-old girl who was found to have a cranial nerve 6 palsy and right extremity weakness. Had a biopsy done, was found to have a DIPG, completed fractionated radiotherapy, and you can see the impressive T2 sequence MRI scans of the infiltrative DIPG and expansion of the PONS itself. So this was the first globally treated patient, pediatric patient with DIPG with sonodynamic therapy. This is just a picture of how the treatments were planned. Again, on the right side of the brainstem initially, for again assessing safety first. The patient did very well, and subsequently underwent treatment of the left side a month later. So the treatment summary: there were 28 overlapping targets. Sonications were run at 200 joules as the acoustic energy, 50 watts for 100 seconds each. There were no adverse events, so no hemorrhages, after the procedure that were found, and the patient woke up from the procedure very well. As I mentioned, the left PONS was treated approximately a month later, a larger area that was more enhancing, but again, thankfully, no adverse events, and the patient tolerated the procedure very well. These are some images for that patient. Again, post-radiation therapy on the left, and then 3 months post-treatment on the right, with some reduction in the dimensions of the tumor itself. So that was exciting to see, but again, no conclusions can be drawn. We're just taking this, in a conservative way and assessing the safety and feasibility, and then again, coming up with the dosages that could potentially have some impact. So that sort of summarizes the sonodynamic therapy. The other exciting trial that we're conducting is the blood-brain barrier disruption, specifically with doxorubicin, and I'll explain why this medication was treated. But what's exciting about the blood-brain barrier disruption is that there is the potential for many different clinical trials because of the other types of either chemotherapy agents that can be used or immunotherapy agents. And so I think that in the future, we'll see more and more applications of this particular a mechanism with blood-brain barrier disruption. Again, sometimes it can be confusing where when you read about low-intensity focused ultrasound, sonodynamic therapy and blood-brain barrier disruption are combined together, but the mechanisms behind both those treatment modalities are different. And so I want to emphasize that point as well. So looking at blood-brain barrier disruption, as we know, the endothelial cells essentially form tight junctions, and that limits the therapeutic modalities for certain types of tumors. And so where focused ultrasound can help is with microbubble administrations. The focused ultrasound can be targeted to the area that one would like to treat, and this results in an expansion and compression of these microbubbles that essentially disrupt the tight junctions and allow for molecules, whether they be chemotherapy or immunotherapies, to potentially become more effective in terms of its efficacy. And so there have been many trials and publications with blood-brain barrier disruption and brain tumors itself in the adult population. This is Nir Lipsman's group from Sunnybrook in Toronto, looking at focused ultrasound enhancing delivery of the trastuzumab for HER2-positive brain metastases. And you can see in these pictures that there have been some lesion volume changes on contrast T1-weighted MRIs on the right after delivery. The medication was also radio-labeled, and you can see a considerable increase in uptake of the medication following focused ultrasound blood-brain barrier disruption as well. So certainly has potential for other types of brain tumors in the adult and pediatric population as well. So how is this useful for DIPG and DMGs? So we know that the intact blood-brain barrier is likely responsible for the limited clinical response of chemotherapy for this particular tumor itself. And so the thought is that there can be more therapeutic modalities if this blood-brain barrier can be disrupted. And Dr. Rutka's group in Toronto looked at DIPG xenografts, and what they demonstrated is that there's an integral blood-brain barrier that has been evaluated that can be sonicated with low-intensity focused ultrasound and disrupted. And their group previously reported the feasibility of temporarily disruption and opening of the blood-brain barrier with a normal mirroring brainstem model using focused ultrasound and microbubbles. And they also looked at a combination of chemotherapeutic agents and found that IV administration of doxorubicin in these animal models exhibited a fourfold higher concentration of the drug in these brainstem tumors compared to controls, which was very interesting and really served as the basis for the translation of the clinical trial for pediatric patients with DIPGs. Here you see that the volumetric tumor growth rate was significantly suppressed with the focused ultrasound treated animals. And these tumors also exhibited decreased Ki-67 expression in the doxorubicin group following blood-brain barrier disruption. So again, very exciting results. And again, this served as the basis for the trial BT016 that we're conducting here at Children's National, and the group with Dr. Rutka and Nir Lipsman are doing in Toronto at Sick Kids in Sunnybrook. Essentially, the objective for this is to evaluate the safety and feasibility of the blood-brain barrier opening with doxorubicin, and the endpoints are safety and feasibility, and then also secondarily looking at what the outcomes could be. Inclusion criteria, patients who are aged 5 to 21 years who are diagnosed with DIPG. The tumor size is limited in the inclusion criteria here compared to sonodynamic therapy, between 10 and 30 cc's, and then 4 to 12 weeks from completion of radiation therapy. Certainly there's exclusion criteria in patients who have participated in other trials, who've had progressive disease, a history of Avastin therapy, or signs and symptoms of increased intracranial pressures. This trial is designed, again, with safety in mind. Each patient is treated 3 times with escalation in their sonication volume. So half the tumor is treated initially, followed by 75% of the tumor, followed by the entire tumor itself. And we have treated now 1 patient with 2 cycles. And this is an example of an image where we've targeted the pons itself on the left side, and the image on the right kind of shows that subtle enhancement we see on the left side compared to the right side after the blood-brain barrier has been disrupted. Following 24 hours later, we get another MRI. On the left, you see that subtle enhancement on the left compared to the right. And on the right image, you don't see that enhancement anymore, demonstrating that the blood-brain barrier is again closed. The timing of which, again, we don't know for certain, when it happens, but these are all areas where further research needs to be done and are currently ongoing within animal models and human trials as well. So again, as I mentioned, this is sort of in the beginning of the infancy, really, of focused ultrasound in pediatric patients, and there's many different projects and many different variables that we want to look at in the future, and that's really what's exciting about this trial and these research areas itself. Certainly, with any new type of procedures, there's technical challenges that can occur. And we have troubleshooted, as I mentioned, the head frame placement with pediatric patients. The anterior crossbar is critical. Since the pediatric patients are intubated and the procedures could potentially take longer, we have experienced episodes of hypothermia and tried to mitigate that with various techniques, including bear huggers. The bear hugger here is not MRI compatible, so certainly there can be longer tubing that can be used. We used plastic, almost like trash bag coverings of the body to maintain the heat as well, and that's made a considerable difference. Because the brainstem, again, is deeper and posterior, frame offsets need to be used in order to deliver the focused ultrasound itself, and that's something that's critical for larger tumors. So I want to conclude, as my time is nearing end, by mentioning a few things of what we learned about high-intensity focused ultrasound. So we talked about how it's a non-invasive means for delivering thermal energy, and there's applications for brain tumors, but certainly we probably will see applications for epilepsy, functional and movement disorders, both in the adult and pediatric population. As I mentioned, we are going to be starting a trial for dystonia in the pediatric population. To date, there's been minimal morbidity in the small number of cases, but there are limitations in high-intensity focused ultrasound, and that's namely the target volume itself. Given the high intensity of the focused ultrasound, there's only a certain size in the treatment window that can be utilized, and that's something to consider when selecting patients itself. If there is a cyst related to the tumor or a tumor that's near the ventricle itself, that creates a heat sink, and sometimes it's harder to achieve the energy needed to result in an ablation. With the system that we have right now, we're unable to do superficial lesions for a high-intensity focused ultrasound. And obviously there's, working with the hospital system and administration, financial implications and discussions also are at play, and currently these procedures are not reimbursed and need to be on a study. So while it is exciting, it's not an answer to every problem within neurosurgery or neuro-oncology, but something that we'll continue to study and see what patients can be selected. In terms of low-intensity focused ultrasound, this is what really excites me the most. It's a powerful method. As I have talked about, there's 2 trials currently, one with sonodynamic therapy and one with blood-brain barrier disruption and doxorubicin. Many protocols can be developed over time to deliver therapeutic agents to targeted tumors, whether that's DIPG or other recurrent tumors, and particularly for agents that do not cross the blood-brain barrier. this can be a time-consuming procedure depending on the focused ultrasound system that's being utilized. And as time moves on, I'm sure we will see incremental steps towards more efficient methods of this particular therapeutic modality. But again, what's exciting is that you can potentially use immunotherapies, molecular interventions, genetic manipulations in combination with low intensity focused ultrasound. So what's the future? There's going to be innovations in transducers. We're learning about acoustic energy dosage. There's many variables involved in the treatment itself, and so understanding the physics behind these treatments are also extremely important. I do believe we'll see expanded indications for functional neurosurgery, OCD, depression, eating disorders. As I mentioned, there can be more treatment approaches related to blood-brain barrier manipulation. And future procedures will really involve, in our trials, drug and energy dose combinations with assessment of safety, clinical radiographic outcomes, treatment efficacy, and so on. So this really signals an innovative approach for pediatric brain tumors, particularly those that remain challenging to treat. I'll end by just talking about Children's National Hospital, where I practice right now. We're really a dedicated pediatric neurosurgery service with 5 attending neurosurgeons. We have many residents that we train from Georgetown, George Washington University, the NIH, as well as the military hospital systems. We're really trying to make an impact on the innovations within neurosurgery, particularly with pediatric neurosurgery. We're using focused ultrasound, laser, lit therapy, developing programs for fetal repair of myelomeningocele, using augmented reality and AI in our treatment plans for brain tumor surgeries. Some pictures of Washington, D.C. I really welcome, if anyone, any of the trainees or anyone wants to visit us or any of the programs here in Washington, D.C., we really welcome you. Feel free to stay in touch with me, and I'm happy to help anyone, achieve their goals within medicine, within neurosurgery or neuro-oncology. I really want to thank the brain tumor team here at Children's National. All these people are integral, and I'm sure I'm missing some people as well, but it really takes a large team to start these trials, and I'm so thankful for each and every one of the people listed here. And again, I want to thank you for this opportunity. This is my email address. Feel free to contact me with any questions.